Hi, my name is Jasmine Whitehead, and today I'll be discussing the article titled Associations Between Mental Health Competence, Indicators of Physical Health and Cognitive Development in 11-year-olds, findings from the UK Millennium Cohort Study by Stephen Hope, Emile Rigaud, Jessica Dayton, Catherine Law, and Anna Pierce. I will be briefly summarizing an introduction, methods, and results of the study while also discussing how it's relevant to clinical psychology in the real world. So, what is my study about? Well, the article aims to evaluate potential effects that the quality of mental health may have on the development of good physical health and cognitive development that may arrive during childhood. In order to assess the relationship between socio-demographic patterning, mental health difficulties, or MHD, and the correlation between physical health and cognitive development, this team conducted a study using a sample of children from the UK while also implementing previously conducted survey items paired with their own skill-based measure of assessment on positive mental health or mental health competence. So, what is mental health competence? Well, mental health competence, or MHC, is an approach to positive mental health that was developed specifically for public health research. It outlines 5 developmental tasks and abilities that children are expected to accomplish by early to mid-childhood, including learning approaches, pro-social and helpful behavior, openness to trying new things, responsibility and respect, and overall social competence. And when categorizing mental health competence, a dual continuum model based on mental health and challenges is used. It should also be noted that while individuals may not exhibit low levels of MHD or mental illness, that does not mean that they necessarily have high levels of good mental health or mental health competence and vice versa. Some of the qualities of this study include that the researchers initially set out to develop a population measure for MHC for individuals of the age of 11, this age being thought to represent an important juncture between childhood and adolescence, as well as a bridge between primary and secondary education. The Millennium Cohort Study then provided the data that would be applied to construct a measure for MHC that utilized responses reported by teachers and mothers from public health research surveys. In addition, the team also decided to look into MHC's socioeconomic and demographic patterning using a variety of social detriments of health-related variables, and in an effort to broaden the body of evidence, the correlation between mental health competence and 3 other commonly used measures of a child's physical health, including unintentional injury, BMI status, and asthma symptoms, were looked at, as well as 3 critical areas of mid-childhood cognitive development that may have influenced variations of MHC. These indicators also included spatial memory, verbal ability, and risk-taking. In particular, it was predicted that greater levels of MHC, which indicate strong pro-social and learning skills, would be linked to improved physical health and cognitive development. So, some of the methods used during the study include mental health competence, mental health difficulties, physical health, and cognitive development, as well as subcategories for physical health and cognitive development. The reports submitted from mothers and teachers were obtained from the Strengths and Difficulties questionnaire, which served as a basis for nearly all of the teachers and mothers' responses and any questions pertaining to the goal of the study that was gathered from these 3 scales, such as hyperactivity, conduct issues, and prosocial behaviors. Mothers and teachers also independently completed 5 items from the SDQ Emotional Symptom Scale that analyzed mental health difficulties in order to determine the total of kids experiencing the most severe emotional challenges, and then those item responses were then compiled and categorized on a scale. The MHC exposure measure included items from other SDQ scales, as well as conduct problems, hyperactivity, and prosocial behavior. And as a result, these scales were not used to gauge mental health difficulties. So, some of the measures that were included include the 3 outcomes under physical health, which were symptoms of asthma, childhood injuries, and overweight or obesity in childhood. In regards to the data collected, the age and sex cutoff points were all adjusted for children. Injuries an individual accumulated during their childhood included the number of times a child was brought to a hospital, health center, walk-in facility, or taken to a doctor for an unintentional injury. And the symptoms of asthma as well were then also broken into 3 categories, such as no asthma symptoms, 2 or more asthma symptoms, or severe asthma symptoms. Moving on to cognitive development, the 3 other outcomes included were risk-taking skills, verbal ability, and spatial working memory. Verbal abilities were comprised of verbal reasoning and verbal knowledge, and these tests were based on the age of the child at the time of assessment. Each group for the child's capacity to retain, retrieve, and manipulate objects in working memory, as well as quantified strategy and error and response latency measures were also used in the spatial working memory test. For risk-taking, the decision-making abilities also included things such as decision-making duration, decision-making quality, delay aversion, and overall proportionate wager and risk adjustment. So, some of the results that were found by the study include that despite the fact that MHC and MHD were associated, it appeared that from the review data, MHC captured more information than the lack of MHD, and children from socially disadvantaged households were less likely to have higher MHC levels. Children falling under other categories for MHC, particularly those with lower, high, moderate MHC, also had lower cognitive development and lower physical health in comparison to their high MHC counterparts. For instance, there was a greater likelihood that a child with lower language skills had also low MHC assessments and also experienced 2 or more unintentional injuries during their childhood. And similar tendencies were also found in MHC responses provided from instructors. Children from lower MHC were also typically from lower socioeconomic backgrounds or from others with psychological distress. This also helped determine that mental health competence and mental health difficulties were not an inverse of one another, as a large portion of the sample of children that were scored either had high MHC and high MHD or low MHC and low MHD. Low MHC was significantly associated with numerous injuries, obesity, and 2 or more asthma symptoms, meaning individuals with low MHC had a higher probability of having poor physical health on the evaluated indicators than those in the high MHC class. And this shows as children in the Millennium Cohort Study who came from underprivileged backgrounds who were also more likely to have worsening mental health. Overall, having positive mental health is more than just not exhibiting any mental health difficulties, and yet there's minimal and sometimes contradictory data relating to positive mental health and a population level of childhood health. The results of the study indicate that high MHC may have implications for improving public health and academic performance, given that it is linked to improved outcomes and measures of physical health and cognitive development at the end of primary school. So, what does this study mean in a clinical psychologist sort of setting? The study has a significant effect and impact in the field of clinical psychology, given that it illustrates how cultivating positive external sources such as interpersonal relationships or societal expectations, in addition to internal attributes with things such as cognitive function and physical health, is necessary for achieving full positive mental health. This point of view also aids clinical psychologists in comprehending the ways in which an individual's social environment may impact physical health and mental health, particularly throughout childhood, considering that that is when a person is most naturally absorbent in new information that is demonstrated to them. Regardless of whether or not a person has high mental health competence, long-term social difficulties such as social isolation, stigma, prejudice, or low self-esteem are all capable in having a detrimental effect on that individual's mental health. The topic of the discussion also raises an array of potential questions concerning the ways in which high mental health difficulties influence an individual's behavior or thought process at different ends of the cognitive development spectrum in terms to their overall quality of life. In a real-world setting, a clinical psychologist may look at how children who are in a higher percentile or children who are lower in the percentile for cognitive development may frequently feel more alienated in social settings as a result to their greater deviations from the norm. In this potential physical isolation or mental disconnection from social settings also creates a high risk for damaging long-term effects on a individual's overall psychological well-being as they grow older. As far as mental health goes and mental health competence, the study basically summarized that mental health competence is something that is greatly influenced by your external sources as well as your internal sources. And one or the other is just as important when talking about that influence. Thank you for listening to my presentation and have a great day.